Best estimates now suggest that medical mistakes in Britain could be partly responsible for 40,000 deaths each year. This would make error the third biggest killer in the country. The size of the problem indicates it's not just the result of incompetent doctors. There is a taboo about doctors making public admission of mistakes. At best, doctors discuss their errors with trusted colleagues in hushed tones behind closed doors. But unless the extent of the problem is brought out into the open, nothing will change. Through the first-hand testimony of those few doctors and nurses who are prepared to talk about medical error, we have pieced together a unique overview of where mistakes occur. It's the essential first step on the long journey to understanding why. The obvious problem area is with inexperienced doctors.
I'm in a very privileged position as an editor of a medical journal. I can say what I want. I mean, maybe I'll get fired, but I doubt it. And I think it's very important to draw attention to this problem.
When Richard Smith was a junior doctor, he trained in an accident and emergency department. One day, a young boy came in with a broken arm. At the time, the procedure was to inject an anesthetic into the arm so that the broken bone could be manipulated without pain. But before doing so, an inflatable cuff was pumped up round the upper arm so that the anesthetic remained localized.
I injected this drug, which is potentially a very powerful drug, and I realized that the cuff had deflated. It wasn't blown up. So in effect, this drug went straight into this little boy's body. It's 30 years ago, but I can still remember it pretty vividly. Just a moment of, horror, almost your heart stopping and breaking out in a sweat and thinking, oh my goodness, what on earth is going to happen here? Am I now going to watch this little boy have a fit and suffer some dire consequences? But very luckily for me, absolutely nothing happened. The boy was fine. All doctors have stories like that.
This simple mistake, made when Richard Smith was a young doctor, is typical of the estimated 320,000 errors a year. Many of them minor, but potentially lethal. Young, inexperienced doctors are too often put into situations in which they're likely to make mistakes. As juniors, they're expected to carry out often unsupervised procedures which they have only ever seen before. We, the patients, are their guinea pigs. In the United States, medical errors have been in the public arena for a lot longer. A few brave doctors are campaigning to alert people to the problem by discussing their own mistakes.
We expect people to learn on patients, assuming that that's the most economical way, since patients are very available, which ultimately, like any other trial and error, obviously there's going to be multiple errors up front until you pass that learning curve.
Paul Barak, who is now a senior consultant at Massachusetts General Hospital in Boston, made a mistake as a junior doctor that directly contributed to a patient's death. He began a procedure on an elderly patient which entailed finding a vein an inch under the surface of the skin. He had never done this before and was glad of the supervision of a senior colleague. But suddenly, the colleague was wanted elsewhere to attend an emergency.
The beeper of my senior resident, who was right next to me, went off, and at the same time there was an overhead page for him for a cardiac arrest, a code blue, just down the corridor. Initially he sort of hesitated since we were in the middle of this, but another nurse came running down the corridor and asked him to come immediately. He looked at me and he said, why don't you continue this and I'll just be down the corridor. And I said, I haven't done one of these. And he said, well, that's okay. You're a good student. I've seen you do work before. You'll do just fine. He tore off his gown and he ran down the corridor. I proceeded to take this larger needle in an effort to locate the vein, which is about 1 inch beneath the skin level. And in the process of looking for the vein with the larger needle, the patient started having trouble breathing.
Dr. Barak had accidentally pierced the lining of the lung. The subsequent air was now forcing down onto the lung and stopping it from expanding. At the time, Dr. Barak had no idea why she was having breathing problems, but he knew he had to react quickly. he ordered the nurse to give the patient oxygen.
And now she was in severe respiratory distress. She could not breathe on her own. So the senior resident came by and he started yelling at me why I did it, and asked the nurse for a needle and stuck it just beneath her clavicle, and you could hear like a whoosh of air come out. And what this patient had was what we call a tension pneumothorax, which is air under pressure, not allowing the lung to expand. And once the air was out, she felt a lot better. Unfortunately, over the next several days, her condition got worse, and about 4 days later, she passed away. I felt very, very bad after this, and every time I put a central line in, that's what's on my mind. That woman, her name, her face, she's with me every day.
As with many junior doctors, Paul Barak's inexperience was his undoing.
Junior physicians are given lots of responsibility and sometimes feel very overwhelmed because there's nobody overseeing them and helping them. And therefore, they have to find their own way. And they use their intuition and they use all the skills they can bring to bear. But obviously, that's not equivalent to experience.
But mistakes are not restricted to juniors. Serious mistakes can be made by experienced doctors and nurses when they are pushed beyond their limits. Operating theatre nurse Jo Fox and her team had been on duty for nearly 17 hours. The team were all experienced, but they were also tired, and there were still 2 patients to operate on. The perfect setting for a mix-up.
One was a young woman coming up for investigations for infertility, which would have included a D&C, and another one was for tubal ligation, which is a tube tie for sterilisation. And this is at the end of a very busy day, so everybody was getting a bit tired and, you know, things were a bit stressed. Suffice it to say, there was a mix-up between which theatre a patient was designated for, and it wasn't realised until the other patient came to the consultant's theatre and the anaesthetist checked the notes and realised he had the wrong patient. They managed to rush into the other theatre just in time to stop this poor lady's tubes being tied, and you know, it really was that close. When lists are running late, people perhaps haven't had the proper breaks. Doctors probably been up all night the night before, on call. All these sort of things make for a very stressed working environment.
Fatigue is a common cause of error, but in hospital, medics have the added pressure of having to achieve targets for the amount of patient procedures they carry out. The targets demanded of them are often without regard to the type of treatment. It's fine for the hospital managers, but not so good if you're a patient. William Notcutt is a consultant anaesthetist at Great Yarmouth in Norfolk. He knows that each patient should get a full medical examination before he puts them to sleep. But time in hospital is at a premium.
Okay, fine. And you're having a gallbladder operation, right?
Mm-hmm, yeah.
Okay. You understand all about it?
Yes.
You know what's going on. Okay. They give you a tablet on the ward?
Yes.
Good. Okay.
At medical school, we're taught to do a full clinical examination and history on every patient. Now, if you really do that, that will maybe take you 15, 20 minutes. I've got 5 minutes to see a patient before an operation. And so I have to reduce what I do to what I accept as the barest minimum. And this is part of the trade-off. And we know then that inevitably you're going to miss the rare things and the occasional things. And really every doctor is in this situation, whether it's an anaesthetist as I am, GP, surgeon, everybody is doing this sort of trade-off. The ideal, which will take time and of course mean that we only see a few patients, against putting too much through and really then getting dangerous and risky.